All right, I'm going to start letting people in. Okay. All right. Hi, everyone. I'm just going to wait a few minutes for some other people to join. All right, as you're coming in, welcome to our live session today. I'll just be waiting a few minutes for some other extra stragglers to join our presentation today. In just a few minutes, I'll start with a quick startup presentation. All right, I think that's everything we're going to be seeing today. So I'll start up with the startup presentation. All right, so hi everyone, and welcome to our live session today. I'm going to be going over a quick startup presentation to welcome any newcomers and also introduce you to our program and some opportunities if you have not previously attended our shadowing sessions or if this is your first one. First thing, we do request that you make sure to mute yourself so we're not disturbing the presentation or anything like that to ensure everyone has their complete and full attention on our professional while he's giving his presentation. So Pre-Health Shadowing is a student-led, minority-led, women-led nonprofit organization dedicated to helping prospective healthcare professionals gain access to educational resources, no matter their demographic status or other abilities and things like that. My name is Alyssa Tran, and I am a volunteer with Pre-Health Shadowing. So thank you all for joining today, and we're going to get started. All right.
Oh, me? Okay, great.
Oh, not yet. I'm still going over it. No, it's all good. Okay. All right. So just a little PSA. We do have closed captions, so to accommodate students with their specific needs and things like that. That setting should be available at the bottom of your Zoom if you need the closed captioning. You can also email us at info@prehealthshadowing.com and be sure to save that as a contact in case you need to access us for any help and things like that. All right. If you want to stay in the loop, you can follow us on social media. We are active on Instagram, TikTok, and you can sign up for our email list to never miss a new session whenever it comes up. Okay, so since this is an international program, we want to ask you, where are you Zooming from today? You can drop it in the chat and let us know where you're coming from. I'm in Southern California. All right, Toronto, Charlotte, North Carolina, New York. Awesome. SoCal, awesome. LA, cool. Toronto, awesome. Lots of places. I love to see it all scattered around Bay Area. Perfect. Awesome. Cool. Looks like we're all over the world. We're all over the country. All right. We have some wonderful opportunities for you all as benefits being a part of our program. So you can visit our website to become a student volunteer or team member. And you can also apply to be a part of our leadership team and lead students in various projects and initiatives and other opportunities like that to help you really get involved in the field. And of course, this is a quick little list of some of the roles we have. Of course, there's many more than the ones listed here, and we're also willing to accept new roles if anyone has any new ideas to participate in our organization. If you are a high school student and want to get involved, we have started a program called HTP, High School Training Program for pre-health shadowing, which allows you to connect with college pre-health programs and things like that and get involved in fundraising for PHS and a lot of things like that to really get involved and start to know the program and things like that. And of course, we would also like to ask if you could donate. That would be really helpful to our organization. We are completely student run and volunteer run and working off of around the clock to keep this free and accessible for everyone. Unfortunately, Zoom and our website are not free, and any contribution would be greatly appreciated. So you can scan the QR code or give it to anybody you know who would be willing to help out. All right, so throughout the session today, we also encourage you to drop any questions you may have in the chat box for the speaker or professional to answer. We will have like a Q&A session towards the end after the presentation where we'll bring up the questions for our professional to answer. Okay. And be sure to take good notes as our professional is going over the presentation, as there will be a chance to take a post-shadowing session assessment or quiz that will be available at the end of the session on our website for you to take to get your hours. Okay. And lastly, if you can, we do request that you turn your cameras on. This is by no means like required or anything. We totally understand. If you can't turn it on, totally get it. But we would love it if you could. It would help us make it look like an in-person thing. All right. So now, without further ado, I'd like to welcome Dr. Adrian Holloway, and he can just take you through his presentation. All right, thank you, Dr. Holloway, for joining us today, and you can share your screen whenever you are ready. I'll stop my share.
Okay. Right. So I always do this wrong. So I just want to make sure that when you see this, do you see the presenter view or my view?
Presenter view.
So let's see here. This is better?
Yes.
Yes.
Perfect.
Yeah.
Okay, great, great. So hello, everyone. Thank you for inviting me. Definitely appreciate it. I have two screens. I'm trying to make sure I'm looking in the right camera. So, so give me a second. But thank you for welcoming me to show you the course of my day as a pediatric intensivist. As I said, my name is Adrian Holloway. I'm Associate Professor of Pediatrics at the University of Maryland Medical Center here in Baltimore, Maryland. We're the other ICU that's in the city. So the objectives and flow of things today is to sort of share who I am as a pediatric critical care physician, get a cursory understanding of what pediatric critical care is, share my pathway to pediatric critical care, and then, a day in the life of an academic PICU doctor. And in sharing what an academic PICU doctor is, really sort of share the other jobs and responsibility I have as a member of the faculty at the University of Maryland Children's Hospital and at the School of Medicine. And then in the end, questions, comments, concerns, all that sort of stuff, we'll be able to do together. Way to introduce myself. My name is Adrian. I'm a pediatric intensivist. I mainly do pediatric cardiac critical care, which is the care of children who have congenital heart disease, who are having surgery. And what I do is help get them to the OR, so caring for them pre-surgery, caring for them post-surgery, and then take care of any complications thereafter. Like I said before, I'm Associate Professor of Pediatrics at the University of Maryland School of Medicine. My research interests are global health, capacity building, health equity, and global cardiology and global cardiac critical care. And the other things that I do as an academic physician is I'm the chair of the Pediatric Pharmacy and Therapeutics Committee at our Children's Hospital. I'm the co-chair for the Global Health Subgroup for the Pediatric Acute Lung Injury and Sepsis Investigators Network. I'm also a member of the Maryland the State of Maryland Child Fatality Review, where we every quarter review unexpected child death. So anybody under the age of 18, anyone who dies unexpectedly in the state of Maryland, we review all of those deaths and then give recommendations to the legislature and to the governor. And I am the chair of the Clinical Competence Committee for our critical care fellowship, where we sort of our role is sort of to evaluate the developmental milestones as our fellows sort of mature through our fellowship program. Here's an educational pathway. So I did my undergraduate, I'm an old man, so forgive me. I did my undergraduate at the University of Virginia, where I majored in chemistry. I went to medical school at the Medical College of Virginia. When I was there, it was called Medical College of Virginia. It's now called Virginia Commonwealth University School of Medicine. And then I did my residency in pediatrics at the University of Florida, or also known as Shands Children's Hospital, from 2006 to 2009. And I did my fellowship in Pediatric Critical Care Medicine at Children's National Medical Center from 2009 to 2012. So I've been in practice independently out of training since 2012. So undergraduate, my degree is in chemistry. And I would say fully that I was never a chemist. And if you ask me to do anything chemistry-wise, I don't know how to do that. I did choose my degree out of convenience. I always wanted to be a science major. However, my choice between biology and essentially biochemistry as my degree. Biochemistry had a later class and learned that twice a week. I'm not a morning person, so I chose biochemistry as my degree. And also I thought that, having a degree in biochemistry would be super helpful for me in my future career as a physician. It helped me in one class. My other degree, I have a dual degree, is in African American Studies. And I will say that my degree in African American Studies, the critical appraisal of anthropology and history, intersectionality has actually been much more helpful and more productive in my career as a physician, particularly as I work in an underserved urban environment. I went to medical school, right, for 4 years. And my formative experiences and sort of what sort of shaped what I like were my experiences in underserved populations. My medical school had an inner-city rural program for the first 2 years of medical school, where you could choose to work or have sort of early experiences in an urban environment or a rural environment. So I spent my first year of medical school doing some clinical experiences at the SC clinic in downtown Richmond, Virginia. Other of my colleagues went, to some of the smaller towns out in the counties. But I think one of the things that I enjoyed most about that time in the inner-city rural program for those first years of medical school was working with physicians who understood the patient's deprivation and found a way to ensure that they got the services they need. I loved everything acute care. I didn't like clinic. I didn't like healthy patients. I really enjoyed taking care of sick patients, and I liked all the ICUs that I rotated through in my third and fourth year of medical school. And I think my first exposure was trauma surgery, in which you are doing a lot of acute resuscitation in the ER and the trauma bay. Those patients were going off to the OR, and there were patients that were being cared for in the surgical ICUs. I liked everything but the OR, right? The surgery wasn't nearly as interesting to me, but I love the numbers. I love the tinkering that you get when you're taking care of patients in the ICU, but I also liked the hands-on skills that you need for acute resuscitation. And then I was able to see this in the pediatric ICU in medical school, and it's like, this is really sort of what I want it to be. It's sort of underserved populations, taking care of children, but also taking care of sick patients and helping them get better. And then residency, right? So residency, I did residency and internship at the pediatrics rather, at the University of Florida. It was a 3-year program that includes your internship. And Peds residency is really designed to train general pediatricians. And so there's a lot of clinical and didactic education, but you get a very broad exposure to everything that's pediatrics. And so that's your inpatient rotations into your neonatal ICU, your pediatric ICU, emergency medicine, and newborn nursery. And then lots of elective rotations, things like cardiology, sports medicine, gastroenterology, radiology, etc. And after completion of residency, you can go into practice to be a general pediatrician in any number of sort of ways, right? So many general pediatricians, work, sort of primary care and outpatient job, but also people work in NICUs. They work as pediatric hospitalists. They also can work as hospitalists in the NICU and hospitalists in the pediatric intensive care unit, as sort of as pediatricians, sort of helping sort of the flow of the unit, but ultimate responsibility for the care of the patients will be, the ICU attending. I chose after my PEDS residency to pursue fellowship. And so while I am a board certified pediatrician, right, and maintain my board certification, I don't see myself, I had never worked as a general pediatrician outside of what I did in residency. And these are pictures from our residency program. You can see here we just had mustaches because at the first day of the year, July 1st, we have mustache Mondays. So you grew your mustache out for a month and you wore a mustache for the first day of residency. But we're really here to talk about pediatric critical care. And so I did my fellowship in pediatric critical care medicine at Children's National Medical Center in Washington, D.C., also known as DC Children's. It is a fellowship is really intensive exposure into a specialty field of study. So for instance, cardiology, neonatology, pulmonology, adolescent medicine, emergency medicine, these are all fellowships or what we call subboards under pediatrics. And so most fellowships are 3 years, and it's designed to turn you into an academic practitioner of your field. And so you not only learn the clinical sort of role of your job, but you also have extensive research requirement as part of your fellowship program, which is the main driver as to why fellowships in pediatrics tend to be 3 years. In pediatric critical care, there are subspecialty 4th year programs that exist. Probably the most popular one is cardiac critical care. So after you do your 3 years of residency, your 3 years of fellowship, you can do an added 1 year focusing just in the cardiac ICU. But other fellowships are onco-critical care. So I have colleagues who work at St. Jude who are onco-intensivists, because all the children at St. Jude, their critical illness is driven by the oncologic process that's going on there. And there are other fellowship programs, 1 year programs in neurocritical care. You can also combine fellowships. And so there are people who do combined critical care in cardiology or critical care in neonatology, or very popular is also anesthesia. One of the other ways people filter into pediatric critical care is through the anesthesia route, because there's a significant overlap. And there is an intensive clinical, didactic, and simulation education as part of that. My fellowship was probably 60-40 clinical and 40% research. And you have much fewer rotations in your critical care program, because what you're really focusing on is how to be an ICU practitioner. And so where I did fellowship at DC Children's, your rotations were the PICU, which is sort of a med-surg ICU, neurocritical care, so the neuro ICU, the cardiac ICU. We also did a hefty amount of transport and your research. Transport is important because when you work in an ICU, a significant portion of your patients will come from internal, right? So from your hospital, but a lot of them come from outside. And so learning how to screen, to triage, and to set up transport and how to get the kid to you in the safest way is a skill that does not come naturally. And you're doing this on the phone. And when I trained in fellowship, there was no Zoom, there's very little Cisco. And so you're really doing, getting this information by somebody telling you a story and asking direct questions to sort of figure out how sick a kid is or is not, and how to sort of manage the patient far away from you. Nowadays, we do have things like Zoom and teleconferencing and FaceTime. And so it's gotten much easier to sort of understand what a kid looks like, because you can have them sort of turn your phone around and show them what the kid looks like. But also deciding, do I go by ground? Do I go by air? What's a component of my team? Do I need to send a doctor out on transport? That is what the transport rotation is really centered around, focusing on. And then end of your fellowship program, it doesn't matter which fellowship program you go into, there's an expectation that you have a work product, an academic product, a manuscript that you will produce at the end of your fellowship program. When you're a fellow, you are already a boarded, or already trained and boarded pediatrician. So we'll sit for our pediatric boards while we are actively learning how to be an ICU doctor. And because of that, because we're already trained as pediatricians and we've got, we're sitting for our boards and we've got a license, all that sort of stuff, there's a huge increase in your acuity, responsibility, and procedures and all that sort of stuff that goes along with it. You're in the ICU, so the expectation is all of my patients are sick. All of my patients have critical illness. And then you're sort of learning how to step into that role as the direct provider and sort of learning how to make decisions, how to communicate, and how to actually do the things the patient needs. Airway management, ventilator management, when deciding when the patient needs to go to the OR, all sorts of things are sort of the direct educational and direct patient care responsibilities you have as a fellow. All the pictures here are here by permission. So even patient places, that's my godson right there on high flow. But critical skills, learning airway management, learning invasive hemodynamic monitoring, learning how to resuscitate somebody, learning how to run a code, team management, conflict management, how to deliver bad news, how to teach, because you have a host of learners who are there. You have your junior fellows, you have residents, you have medical students, and residents of all sorts. And the hugest part of PEDS critical care, particularly in these acute settings, is communication, 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 how to effectively communicate to your team, to your colleagues, and with the families of the patients you're caring for. And so this is sort of a smattering, right, of sort of didactic and clinical sort of education that comes with critical care fellowship. And so you can sort of see that there's these sort of host of conferences that we have in the ICU. And so you have your basic science series, sort of talking about the basic sort of science of critical care. So talking about septic shock, ARDS, your pathways, biochemical interactions, those sorts of things. We have a dedicated cardiac critical care conference. We have board review in which we sort of practice board questions. Critical communication encounters, and that's sort of the palliative care sort of component of your fellowship. Learning how to give bad news, how to communicate with families where goals are disparate. A lot of simulation, neurocritical care series. There's some joint series between the Pediatric Emergency Medicine Fellowship and the Pediatric Critical Care Fellowship. And probably one of my favorite sort of rounds are, we call them Christie rounds or Pollock rounds, in which the most senior physicians that we have in our ICU will find a patient in the unit and go to the bedside and will teach, expositorily about a patient, share their experiences caring for the patient, share their pitfalls, share things they've learned about patients in the ICU. And that happens with both the routine and with sort of complex or unexpected cases, unexpected diseases in the ICU. There's also a huge difference between being a first-year fellow and third-year fellow. The first-year fellow is really coming in very green, inexperienced, sort of learning the ropes and stuff like that. And so to that end, you can sort of see here sort of the time they spend in the ICU. They have about 34 to 52 weeks are in the ICU, right? Sort of being a trainee at the bedside. We have 12 weeks of research, and that 12 weeks is really sort of trying to figure out what your research is going to be, and sort of getting sort of your mentors, all this sort of stuff in place, and you get 4 weeks of vacation. But as a third-year fellow, there's only 16 weeks of clinical time. So that's 4 months, out of the 12. And the vast majority of your time as a third-year fellow is working on your research, is getting your academic product ready to be finalized and ready for submission. And depending on your program director, the requirement varies, but everyone who does a fellowship has to have an academic product. And our program director, before she was signed off, let us sit for our boards. We actually had to submit our publication our manuscript for publication. Whether they got accepted or not, that was not a requirement, but we actually had to submit a final product to a journal for publication. So what is pediatric critical care, right? And so it's not neonatology, or it's not emergency medicine. It's its own sort of separate field. And the best way I can describe it, it is the care of children with organ failure, or who at risk for organ failure, or require intensive or frequent monitoring. And that is what the pediatric ICU is. Pediatric ICU docs are generalists, and we have to be comfortable with a wide variety of illnesses. And so as an ICU doctor right now, I have trauma patients, septic shock patients, patients with surgical emergencies, children with cardiac disease, infectious disease, cancer, respiratory failure, organ transplant, bone marrow transplant, burn, endocrine emergencies. And so you have to be able to take care of all of those diseases and be able to care for them effectively, which lends to why our fellowship tends to be much longer, because we have a wide variety of ages. We go from 0 to 21 or 0 to 18, depending on your ICU, and we have this mixture of disease processes that are ongoing at the same time in the ICU. Unlike other specialists, like a cardiologist or a pulmonologist or a rheumatologist, we don't own an organ system, meaning there is not a single organ system that I'm specialized in, but we are in charge of the holistic care of the patients. And so why that's important is I have to know how organ systems talk with each other when they're failing or failed. Okay, so how the heart and lungs are going to talk to each other when the heart is failing. How does the liver and the kidneys talk when you have heart failure or when you have respiratory failure? How do I ensure that I have adequate cardiac output and oxygen delivery with a patient with cancer who is anemic but also has kidney dysfunction and fluid overload? And so talking about those organs talk to each other when they're failing is probably the most important job that we have. And I'm largely charged of organ support. So the ventilators and the kidneys and the dialysis machines, ECMO, all those sorts of things, I'm in charge of that. I make the decision about who needs organ support, make a decision about how we get to organ support, and I'm in charge of the team that's sort of managing that. And so that is what I do as an ICU doctor. And so I just want to sort of give some examples of sort of these sort of how you get into the ICU. These are not exhaustive, but sort of exemplify what I'm talking about. So the question is, what do I mean by organ failure? So a case is a 1-month-old baby has RSV bronchiolitis. It's very common, particularly in the winter. That kid has increased work of breathing and low oxygen saturations, despite being on oxygen. And so that baby is intubated for respiratory failure and admitted to ICU, right? And so that organ failure, that respiratory failure is enough to get you into the ICU. And all the things that sort of go along with decision-making about how do I take care of a baby with respiratory failure? What access do I have to have for this kid to make sure they get critical medications, deciding about antibiotics, no antibiotics, sedation, feeding, all of that sort of goes together. So at risk for organ failure, right? And so sometimes we get kids to ICU who have, from the outside, nothing's wrong with them. And so a classic sort of case of this is a 16-year-old who's riding ATV, has a rollover accident. He luckily was wearing a helmet and only has a mild concussion. When he got to the hospital, he was complaining of abdominal pain and was found to have a grade 3 to 4 splenic and liver lacerations. So you can sort of see here in this picture, spleen is down here, liver's up here. You can see this dark stuff, that's blood, okay? Because of a roll accident. And so he was mildly anemic in the trauma bay, but otherwise everything was stable. But he's admitted to the ICU for frequent monitoring of blood hemoglobin levels every 4 hours and frequent abdominal examinations, right? Because what is it risk for? He's at worst risk for severe hemorrhage, right? And bleeding to death. And so in the ICU, because I can do frequent laboratory draws and I can do frequent examinations of his belly, if he worsens, I have the ability to respond much more rapidly if he was in a different unit and save him from having what's called hemorrhagic shock if the bleeding gets worse. Frequent monitoring is another way you get into the ICU. So this story is a baby who's 4 years old with a history of extreme prematurity and severe anoxic brain injury, meaning she has injury to her brain because it didn't receive enough oxygen for one reason or another. She's admitted with fever and increased secretions from her trach. Usually the child is cared for at home and there's home nursing, but she has a tracheostomy, which is a breathing tube that goes into the neck. She has a ventilator that goes with it, a surgically placed feeding tube, VP shunt, and has probably 12 medications for things such as a seizure disorder, spasticity, reflux, asthma, and dysautonomia. And so that sometimes these children come to ICU because the nursing needs are too intensive for the inpatient ward. And so the ratio of patients, on the floor, it may be one nurse for 5 or 6 patients. The most number of patients most patients a nurse will have in the ICU is 2. And so the ratio of provider to patient skews to being more protective of children who might be fragile. And what do I mean by intensive monitoring? And so another way you get into the ICU is this way. So this story is a 9-year-old with high-risk metastatic neuroblastoma. There's a new protocol that requires a high-risk chemotherapy drug. The child is in his usual state of health and has no critical care needs. The new chemotherapy agent has significant risk of papillary leak syndrome, anaphylaxis, and pulmonary hemorrhage, right? All bad things if you give chemo. And about 1 in 10 children who get this new drug do require intubation, even though it's for a short period of time. And so because of the risk of medication and the sort of high risk of organ failure given this medication, that child will be admitted to ICU for close monitoring. So we can follow this child's course while they get this chemotherapy drug. So I stop here. Any questions, comments, concerns, anything from the audience about anything I said? Cool.
Sorry.
Yes.
I just missed, would you be able to go over the coverage that children within the ICU gets? Or you mentioned something about 2 nurses per child. I just missed, I just was looking at something else.
Yeah, no. So one of the benefits of ICU is the ratio of provider to patient.
Mm-hmm.
And so most patients are 1-to-1, meaning 1 nurse, 1 patient. But that ratio only goes, the max number of patients a nurse can have is 2.
Mm-hmm.
So when you have, maybe not so sick kid, but otherwise fragile, that kid won't fall through the cracks in other settings because the nursing ratio is skewed to be more protective of the patient. Does that make sense?
Yes, that makes sense. Thank you.
All right. And sometimes we will have 2 nurses to a patient, right? So a super sick patient will have, multiple nurses caring for them, particularly if you're thinking about adding in other sort of organ supports, which we can go into in a little bit. But yes, so I'd like to share with you a day in the life of me as an ICU doctor, with a little bit of drama, to make it fun. But a little bit about my environment in the ICU. So I work in an urban academic pediatric ICU So I'm right here in downtown Baltimore, and from my office, I can see the Orioles Stadium. We have 19 beds, and our ages that we admit are from age 0 up to age 21. And that 21 age limit can be pushed, particularly if there are young adults with pediatric disease. And so classically what will happen is you'll have a 25-year-old with a history of prepared congenital heart disease, and they need a redo. And the place that knows how to take care of those patients with that surgery, with that lesion, is probably the cardiac ICU. And so occasionally we will admit 25, 26, and 27-year-olds if they have sort of intensive surgery, but we really try and keep our age below 21 and try and keep that really below the age of 18 or 18 and under. We are mixed cardiac and med surg ICU. There's certain ICUs where they have a separate cardiac ICU and a separate PICU. We have a single unit with 2 service lines. There are 2 attendings on during the day. So there are 2 ICU docs during the daytime with their whole team, and then 1 ICU doctor at night. And we have fellows, so people who are learning how to do pediatric critical care. We have advanced practice providers, so physician associates, nurse practitioners. We have residents, and these are physicians who are learning how to be pediatricians, and so they have to rotate through the ICU. We will also have emergency medicine residents and combined residents rotate with us. And so we have 2 combined programs at University of Maryland. There's emergency medicine peds residency program, and then it's an internal medicine pediatrics program. And so they will also do a couple of rotations with us in the ICU. And we have a multidisciplinary team of specialists. And so we have everything from child life to social work, chaplain, et cetera, who are dedicated to the ICU. And so this year, sort of pictures of, the ICU, the hospital I work at, and sort of components of our team here in the ICU. So my day starts at 7 o'clock when I am on service, and it starts with sign out. And so I come in and I do attending sign out. And so the nighttime doc is telling me the overnight events in sort of real sort of quick fashion, go over new admissions, and also sort of identify hotspots and troubles. And hotspots and troubles are kids who are newly unstable or who have developed new organ failure, or even sort of social concerns. Sort of knowing sort of where attention needs to be focused. After I get signed out from my colleague and I send them home, I go in and check on the sickest kids and the ones I'm worried about. Like you don't have an opportunity to see everybody in the ICU, but I'll check in on the sickest ones, make some adjustments if I need to. I briefly check in with a charge nurse, sort of ask, anything you're worried about, what's the gossip, what's the tea, what's going on there. And then I'll go in and check in with my residents and my fellows. Like, what's your plan? What are you doing today? Have you seen this? Go address that, etc. And then at 7:30, we have what's called cardiac ICU X-ray rounds. And so these are sit-down rounds that we do with our cardiac surgeon. And so we're really focused on this portion on reviewing the kids who actually just had surgery. And so we are focused post-surgical patients, looking at X-rays, looking at your ins and outs, and when to remove your invasive devices or how to maintain them. We also get updates on admitted kids with congenital heart disease or heart failure, for checking in and sort of deciding, how do we advance their care? Do these kids need transplant evaluation? Do these kids need extracorporeal support? We'll also discuss our ORs for the upcoming day. And we do this sort of sitting, in a boardroom with, a sort of big screen going on everything. And so just sharing with you here, this X-ray. As you can see here, we review all our lines, tubes, and devices. So here is a breathing tube, endotracheal tube, make sure that's in good position. You see these big sort of honking sort of white lines. These are chest tubes, so there are 3 of them. So one goes that way, one comes up that way and curves around, and there's one sort of sitting right here. We also have wires for our temporary pacemaker. So coming up here, probably hidden back here in the atria, right here, and then 2 on the ventricle. This left ventricle right here, and the wires coming out of the patient sort of hanging out. And so this were connected to the patient. And so we'll make a decision about what to do with diuretics, what to do with our vasoactives, sort of in a team discussion, and we move forward to operationalize that. And then here's a kid with a big heart from heart failure, dilated cardiomyopathy. And so we'll check in, is the kid able to eat? Has the kid weaned respiratory support? Are we escalating, et cetera? And we make different decisions about what to do with this kid with the surgeon. Does this kid need a ventricular assist device? Does this kid need, to be cannulated ECMO, et cetera, et cetera, et cetera. And so we do this from 7:30 to about 8 o'clock. And then about 8:15, we have a nursing huddle at the whiteboard. Okay, and so this is a very high level discussion about flow of the unit. So we are talking about anticipated transfers out of the ICU or discharges. We talk about the holistic sort of children's hospital bed flow. And so we sort of know, are there beds in the NICU? And are there, sort of laboring moms with, preemies? What's the ER looking like? Are there, et cetera, sort of how we can move children through the ICU or through the children's hospital, and sort of figuring out how we can adjust our plan to make bed flow work better. We talk about our anticipated travels. And so we're taking kids to MRI, or kids are going to the OR for procedures, or travel to hyperbaric chamber, or talk about our sedations and our procedure. So part of the job in the ICU is that we'll have kids who come to the ICU for sedation for a procedure. For instance, that will include like burn washouts, wound washouts, placing central lines, doing sedated lumbar puncture and stuff like that. And so we'll do sedation for that in the ICU. We also will check in with social work, case management, and chaplain. Case management, really sort of working on home equipment, talking about insurance issues, setting up things like home nursing. Social work, evaluating the social concerns, transplant evaluations, updates from agencies. A fair amount of child abuse and child neglect comes through the pediatric ICU. And so if there are like child protective services or police agencies that you communicate, they usually communicate through the social worker. And so he or she will give us those updates. And then chaplain, so bilateral updates, understanding sort of family support needs and check-ins to make sure that we are sort of caring for the patient holistically. And so official rounds at the bedside start close to 8:30. And we do bedside rounds, and there are teaching rounds and work rounds. And in that, we sort of walk from bedside to bedside and sort of have formal presentation about the care of the patient. At this time, I've probably re-examined the kids I'm worried about the most, making sure that my escalation, de-escalation plans are actually possible to be done. And with this, we actually round with families as a critical part of the team, so they can be part of the decision making and also know what's going on with their child or loved one who's admitted to ICU. And with that, we also discuss our goals and our safety. And so, and these are mostly led by the nurses, who will check on central line, Foley catheters, which sort of sit in the bladder, clot prophylaxis, movement, feeding, all sorts of things what we'll discuss to make sure we walk away from the bedside that we've discussed our plan and our goals for the patient. We've also made sure we address all the safety standards and parameters for a patient as well. And so that our nursing is really responsible for ensuring that we complete that. And so surrounding a patient is a whole host of experts. And when I have a fellow on with me, who is attending in the ICU, are sort of in charge of the team, but my goal is to give that responsibility over to the fellow who is learning how to manage a team of experts. And so every day on the rounds, we have this complement of people at the bedside. We have myself as attending, my fellow, a resident, the frontline nurse, the family if they're available, and then a host of consultants, pharmacists, and dietitian. And so how things usually go is that the resident will sort of orient us to who the patient is. And so the resident will say, we'll make up a scenario for this kid. This is a newborn baby admitted from home with seizures secondary to meningitis. And so the resident will give us that piece of information. The frontline nurse or the bedside nurse will tell us the overnight events. And so things such as, well, we had a fever last night and we sent cultures. Our sedation was suboptimal. So we had a couple of brain DSATs, gave this many of extra doses of medication. And we'll also review, we have a central line that is this many days old. The breathing tube is secured at this place with our vent settings, et cetera, et cetera, et cetera. We turn it back over to the resident who will give the plan. And so give the physical exam features, review the laboratory data, and give us a very specific plan about how to manage the ventilator, how to manage the antibiotics, what we'll do with the anti-epileptics, and then give our goals to everyone. And so our goal saturations are this, our goal blood pressure is this, our goal urine output is this, etc. In a very prescribed way so that everyone on the team knows. And so anyone on the team that sees that a patient is not meeting goal can alert the team and we can either intervene or make adjustments. After that, our pharmacist usually chimes in, and particularly if we have medications that we are checking drug levels on, they're also checking to make sure that we are mindful of dosing adjustments. If a patient has kidney failure or liver failure, making sure there's no drug interactions, and then sort of optimizing dosing and drug choice in these settings. Our dietitian will also give input on feeding and optimal nutrition. We'll make a decision if the kid is safe to be fed into their gut. And kids are intubated, really don't feed by mouth. And so we'll usually have a feeding tube into their belly. And if they can't tolerate feeding into their stomach or to their intestine, then we're talking about, do we do IV nutrition and making decisions about that. Our consultants are usually, will either pop in or at the bedside. Consultants we see usually every day in the ICU are going to be a general surgeon, infectious disease, cardiology, and neurology. We usually talk to them at least once a day, every day. Others, you might see genetics or HEMOC or other specialists coming in to sort of their patient admitted to the ICU. And then others who you might have at the bedside, depending on sort of what's there, our social work, physical therapy. Physical therapists may say, hey, this kid is starting to show evidence of foot drop and wrist drop. So we're going to create some braces and talk to the nurses about doing range of motion while the kid is still intubated. And speech pathologists. And so getting kids to feeding by mouth after critical illness is super important. And so speech pathologists may say, hey, when this kid is better and is off the breathing machines, I need this kid to have a speech eval with me before we know the kid is safe to eat by mouth. And so this is sort of the complement of people who are at the bedside for every patient when we round in the ICU. And it's very important that we hear from their perspective because it helps me and helps my fellow create a comprehensive plan to be able to move the kids forward. And we not forget the family. And so we want families at the bedside. We do family presence for everything. So acute resuscitation and bedside rounds. One, I think it's important for families to know all the information that I have that I'm using to make decisions and also understand the context of decisions. It's also important they have buy-in with the plan. And if not, we sort of can have a conversation about why or why not we can move forward certain things or cannot. So the family is an integral part of our ICU holistic care, but also a very important part of our rounding team. rounds are educational, and so we do a lot of ad hoc teaching at the bedside, either in Socratic method and sort of, tell me what you know about acute respiratory distress syndrome, or tell me why we're using this medication for this patient in this circumstance. Or sometimes I'm just telling you information and giving sort of clarity as to sort of why we're making certain decisions, and then contextualizing them for the residents. I tell the residents always be a thinker. If you know the physiology, if you know your anatomy, if you know sort of the brass tacks of what you do, you don't have to know a lot because you'll be able to figure out the answer. And so here are the residents that I had with me just last week, and they are learning how to sort of work high flow. And so we also do a lot of sort of experiential learning. We'll pull a ventilator, we'll pull a high flow circuit, we'll sort of pull those sort of things, allow the residents and learners to manipulate them themselves and sort of figure out, how to work them, how they work, but also how they feel on their own face if you're going to ask a child to sort of wear them as well. So these are sort of a couple of residents that rotate the ICU right now. In the ICU, there are very few days that go without interruption. And so while we're rounding, while we're doing the work of sort of seeing our patients, we oftentimes end up responding to a host of emergencies. So a patient can decompensate, you have urgent transfers from emergency department or from other hospitals, you get an urgent consult for extracorporeal life support or ECMO, urgent procedures such as intubation or doing CPR, and responding to patients that develop new conditions, new sepsis, new respiratory failure, arrhythmias, etc. And so the interruption. So we're rounding, and so we get a phone call. And so the story is a 14-year-old patient arrives to the emergency department with severe respiratory distress. There's no previous medical history other than she returned from travel to the Philippines just a couple of days ago. The general impression they tell me from the emergency room is she's very weak, very pale, very tired appearing. She's very sweaty and diaphoretic. Her lung exam has crackles and wheezes. The heart exam demonstrates a gallop on a fixed S2 sound, and she has very swollen hands and feet and very cold extremities. Any guesses as to what we might be dealing with? No, yes, no, maybe so. Maybe I'll show you a picture. Okay, so the emergency department is able to get a chest x-ray. See this big old thing in here. Anybody know what that is? What I'm pointing to? Not pneumonia. That's her heart. That's a big old heart in her chest. Okay, so your heart should be less than 50% of this window in your lungs. Okay, so she got a big old heart. And you look at her EKG, and it looks kind of nasty. This is what they're telling you over the phone from the emergency department. EKG doesn't look great. And I'll just tell you what the EKG shows. It has a strain pattern. So you see these segments that are elevated. That shouldn't be that way. And the voltages are a bit higher. So it's telling me she has right ventricular hypertrophy. And then they say, hey, I got some vital signs for you. Heart rate is 143. That's really high for a kid. Her blood pressure is 85/42. That's low for a kid. And SATs are only 94%, which is not great, but could be better. And she's already on oxygen. And then they send an ABG, which tells me acid-base balance in the blood. And the pH is low, so she's acidotic. The normal is 7.4, she's 7.1. And her lactate, which is a measure of anaerobic metabolism, is 6.5. So I say, okay, fellow, you gotta go downstairs, go see this kid. Oh gosh. Okay. So our fellow goes downstairs, and she's seen in the ED, and we diagnosed her with cardiogenic shock, right? So she has a big old heart, and the heart doesn't squeeze very well. And so her body's making acid because of poor cardiac output. And while the fellow was downstairs, the PICU is setting up a room. The patient needs to be intubated, but we think it's very high risk, right? And so we decide, instead of intubating the patient in the emergency department, we decide to move the patient up to the PICU just in case we need ECMO. And so I call my surgeon and say, hey, I got a kid cardiogenic shock, you know, she's intubated. If we get in trouble, we're gonna need you to put the cannulas in. I've talked with, my colleagues, everything is ready just in case something goes bad. And so things aren't great, right? And so this her ventilator, so it shows me her lungs are stiff and boggy. Telling a story. She's on a lot of oxygen support. Here is something called nitric oxide, which is a pulmonary vasodilator to sort of help oxygen move through the body. These are called NIRS, so it's called near infrared regional spectroscopy. And so we're looking at saturations over the head and over the kidneys. A normal number should be above 65, and you see her numbers are low. And we have all these medications running in through a pump here, right? Trying to get her better. But things aren't better after intubation. The lungs are stiff, the heart doesn't squeeze, and the patient's developing worsening organ dysfunction. And so my fellow here, my charge nurse, my bedside nurse, get ready, and we get the kid on ECMO. We get ready to get the kid to be put on ECMO. I call a friend, because there's two of us, right? And so I'm going to be tied up doing this. I need you to take care of the rest of the unit. Also, if you have some extra time, get some things arranged for me while I get this kid to ECMO. And then we do our thing. The surgeon comes over, we set the room up, everybody's sterile, we get the kid nicely onto ECMO, and we get her flowing, and she's all better. And we can sort of figure out what's wrong with her. And so that's our interruption, but we've got to go back to work, okay? So who do you take care of today in our ICU? Who's my service? And so this sort of a HIPAA compliant, not so accurate view of my patient list when I was on service just last week. A 12-year-old diabetic ketoacidosis, a 17-year-old respiratory failure from intentional overdose, a 10-month-old after resection of a large Wilms tumor, so here for post-surgical monitoring. There's a six-week-old with abusive head trauma, also known as shaken baby syndrome. There's another kid on ECMO for persistent pulmonary hypertension who got transferred to us from our NICU. There's a 9-year-old with Guillain-Barré, which is an ascending paralysis syndrome, who was here for close neurologic monitoring. A kid, a 15-year-old who got a posterior sinus fusion for scoliosis. A couple kids with bronchiolitis and high flow cannula. A little baby with chronic lung disease exacerbation. A 5-year-old sickle cell disease admitted for acute chest who needs exchange transfusion. A 21-month-old with trisomy 21 who had OSA and got a tonsillectomy, and an 8-week-old baby with GBS meningitis who's ready to go to the floor. And so one of the things I love about PICU is it's never the same thing, right? I can come in tomorrow, it'll be some of the kids will be here, it'll be a completely different milieu of children in the ICU. And so it really helps my ADHD. And so I can hyper-focus, and then interruption can happen, and I can move on to something else, which I love, right? This fits for me. And so if you don't mind interruptions, you don't mind hyper-focus, you don't mind things changing, in a second, critical care is where you want to be. And so this is why I love it. And I think this is why I function well in a critical care environment. I also have great appreciation for general pediatricians, because even though I've trained as one, I am not one. And in taking my baby to the doctor, to her pediatrician who trained at University of Maryland, I am in awe of all the things that I've forgotten or don't think that are important as a pediatrician. But sort of understanding your assets and your liabilities helps you pick the best career for you. So rounds 10:30 to 12, they're blessedly done. And this is me and a co-fellow. This is me and my hoodie. This is my very last call as a fellow. As you can see, I'm thriving. And this is one of my junior fellows. So after rounds are done, I'm re-examining, reassessing my patients. You talk with families, update plans of care. You have your residents calling and following up with consultants. You're preparing for your planned admissions from the OR. You're setting up kids for transfer out of the PICU. You're taking unplanned admissions and emergencies. You're getting ready for lunch, and I'll tell you, I've never had lunch when I did not work. And it's document, document, document. You got to write everything that you've done down as part of your progress notes, because A, you don't get paid, but if you didn't document it, then it didn't happen. And so then from 12:30 to 4, our day ends at 4. Documentation, documentation, documentation. But then things that we have on our calendar we have to address is our fellowship educational conference. We have to teach the fellows, we have to teach the residents, we have a new admission, so you have to go and evaluate and see them. You're doing and supervising procedures, you're talking with consultants, you're doing family meetings, you're delivering good news, you're delivering bad news, and you're also attending to your other jobs. And as an academic physician, even in a day where you are primarily doing clinical work, you have a lot of administrative and research work that you have to do. So this is my calendar for the week I was on service. So from July 28th through Thursday. And you see here, I have my cardiac surgical rounds, but here you can sort of see I have a couple research meetings. I have my P&T committee meeting, also have our CAP conference meeting in the afternoons, and sort of these sort of touch bases and research meetings and academic and administrative things that we have to do or attend to over the course of the week. So, sort of talk very quickly about the other jobs and responsibilities as an academic physician. So what do you mean by academic physician? Academic physician means I work for a university in some capacity. And so I have a clinical appointment, right? And so I'm qualified to work in the ICU, work in the hospital, and take care of patients. That's my clinical appointment. My academic appointment means I have a faculty appointment to the School of Medicine, and that allows me or qualifies me in some way to treat trainees, so medical students, residents, fellows, etc. And your academic rank is based upon scholarly output. And so it goes from an instructor to full professor, and I'm what we call middle management in the School of Medicine. And so your other responsibilities as an academician are research, teaching, administration, and then external stuff, community service, what we call citizenship. So my research is focused on global health capacity building, global cardiology and cardiac critical care, and health equity. And so I have these ongoing projects that we sort of work on, right? So I have global parity, was a point prevalence study in acute pediatric critical illness in low resource settings. We also have a new project ongoing called Spark Global, which is a point prevalence study validating the Phoenix criteria for sepsis septic shock in low resource settings. I also teach internationally. So we have telesimulation programs for cardiac critical care and tele-QCPR, or what we call quality CPR, in Ethiopia, Nigeria, and Zambia. And then I have a project sort of ongoing, sort of using my global health sort of context of work, is research that is looking at improving outcomes and glucose control in children, Black children with type 1 diabetes, and then also doing bystander CPR. And so going to community centers, teaching parents in the hospital how to do compressions only CPR. One of the things I can say, and in the literature writ large, is that impoverished communities, marginalized communities get lower rates of bystander CPR. So meaning if you drop dead in certain communities, you're not going to get bystander CPR. There's longer EMS response times. There's lower rate of getting responder spontaneous circulation. And for those who survive a cardiac arrest in certain environments, their neurologic outcome is worse. And I'll have this in my ICU at the same time. I'll have a kid who goes to a very well sort of well-resourced, school, and has collapse events on the football field, will get immediate CPR, immediate cardioversion, and walk out with a pacemaker and an intact brain, can no longer play football, but brain is intact. And we'll have the same thing happen in a poor resource community, and delay of CPR is 10 to 12 minutes until EMS arrives, and that child leaves neurologically devastated, does not survive. And I've seen this happen many times with the same disease, same everything. The outcomes are very different because of the community's ability to respond. And so what we're trying to do with this project is really trying to teach people how to respond just do CPR, no breathing, no nothing, just push in the chest and push hard until help arrives. And so that is sort of two projects that I'm trying to put my money where wealth is. Sort of looking at sort of problems globally and then bringing them home to my own community to impact outcomes. And this is a smattering of some of the stuff that we've published with that. And sort of what I try and do is make sure everything that we do is academic and there's productivity with that, because unfortunately, publication is a currency of academic medicine. Teaching. So I have to teach, and I say have to teach, but that's a responsibility of mine. And I enjoy education. I enjoy teaching. And because I think as a pediatrician, you have to know things and you have to be good at taking care of children, because there are very many people who are not good at it. And I also think that the environment that I work in, environment that I come from, I think that pediatricians are a way to obviate some of the risk that communities encounter. And so thinking about globally trained pediatricians who understand structural violence, pediatricians who understand social determinants of health, I think are effective practitioners on the other side. My main focus is, I teach everybody, medical students, residents, etc. The main focus is educating fellows to be independent practitioners, academic practitioners at the end of 3 years. And there's a host of didactic, ad hoc, and procedural education. I do specialized lecture series in cardiac critical care, whiteboard sessions, and we have the great debate. And administration. And so I have this sit on committees that are critical to running the hospital or other services within the Department of Pediatrics or Division of Critical Care. So examples of that is I'm the chair of the Pediatric Pharmacy and Therapeutics Committee. And so with that, I'm in charge of the team that manages selection and use of medications within Children's Hospital. I'm also chair of the Clinical Competence Committee for our Pediatric Critical Care Fellowship. And so I lead the team that reviews the growth and development of our fellows on Critical Care Fellowship. And then I was very briefly a medical school admissions interviewer. I did it for 2 years. Absolutely zero of the kids I recommended for admission to medical school got in. So I was like, I'm out. You know what? You value my opinion. So I'm going to do other things. So, an external community service, right? So that's representing the school or your department well by providing services, expertise, consulting, and volunteering. So, so part of that is I'm part of the Empowering Hearts group. This is a research and educational consortium that is designed to expand access to pediatric cardiology education and training in low resource settings. I am the North American co-chair, all these words, the Global Health Subgroup of PALICI, which is the Pediatric Acute Lung Research Investigators Network. That is a research network with the goal of academic output. And so it's an international consortium of pediatric intensivists, emergency medicine doctors, and general pediatricians who are focused on research that impacts critically ill children in low resource settings. I'm also the pediatric cardiac ICU lead for the Boom Foundation. And so twice a year, I go to Nigeria and we do cardiac surgery. And so I'm the ICU lead for that. And so this global cardiology NGO that's capacity building focused in Nigeria. And then I'm on the state of Maryland Child Fatality Review Board. And so we meet quarterly to review unexpected pediatric deaths in Maryland and then provide those recommendations to the legislature and to the governor. And so these are some of the sort of articles and sort of publications we had sort of results of that work in the community. And so in summary, pediatric critical care is especially that focuses on the care of critically ill or injured children. That is who sort of I'm talking about. And for me, it's the best because I can use my hands and do procedures. I get to talk about esoteric things on occasion, right? So all these weird diseases that come through, or talk about sodium, and for longer than anybody wants to talk about. It fits my ADHD well, right? Lots of variety, change in focus. My dopamine is on point when I'm in the ICU because there's so many things that I can sort of get myself involved in, and occasionally I find myself getting into trouble. Disadvantages, lots of nights, lots of weekends. right? And so, and I work holidays. And so I worked every Christmas from 2006 to 2018. Um, and the reason I got the Christmas off 2018, my daughter was born in November. So, and so that worked nicely for me because, well, I'm not really interested in doing anything for Christmas, right? Because my family is nearby. You know, my family was too far away. I can drop down, visit them for a day. I can hang out and do my own thing. But I also set myself up because vacation was longer if I went away for New Year's. And so I found myself, instead of I work Christmas, and found myself in some warm country for New Year's every year from 2006 to 2018. And so, but the other part of that is I get random Tuesdays off, right? I can go to the gym, I can go to the doctor, you know, in the middle of the week. I can go grocery shopping. I can cook for my family for those times that I'm not on service. And so it, even though sort of you sort of work and sort of a heavy schedule, when I'm off, I'm off. You know, I am not in the building when I start to be in the building. And the other part is that I can leave the patients behind, right? I've turned them over to another competent, duly trained intensivist. And so those patients are in the care of that team. So I can walk away because it's so intense, allow yourself to wash off the intensity of the ICU, to relax, to sort of refill your cup and come back and do it again. Working academic medicine requires clinical expertise. Our old dean said, I don't care if you're a good doctor, that's the minimum, that's the expectation. You need to be contributing to the other parts, to your community, developing your growth and research, administration, education, etc. And I will tell you that has a very steep learning curve. And the learning curves are steep for various reasons. There is a procedural and sort of management component that is very steep. But the thing that I found the hardest is managing humans and learning how to do that because you are an expert leading experts, right? When I am on rounds, the respiratory therapist is a PICU respiratory therapist. The nurse and they're on rounds is an experienced pediatric ICU nurse. The dietitian is a so everyone is an expert in their own field. And so I've got to be able to learn how to take all the information in and then adjust my plan or adjust their plan to move, you know, sort of make it sort of a holistic, comprehensive plan for the patient. And so in that, I'm always learning, right? I'm always seeing diseases that I haven't seen before, and I've been in ICU, you know, since 2009. I see things, I learn new things. The field is always progressing, and so it allows me to stay on top of things and feed my own sort of continued growth and professional growth as a physician. So critical care doesn't allow you to stagnate, which I think is also very cool. And then that's all I have to say. I've yammered at you people who've been paid a lot of attention to me, and I appreciate it so much. But that's all I have to say as far as my presentation. What questions do you have for me? So one of the questions from Yasmin is, I know that some medical roles involve more desk work than others. As academic physician, is your time primarily spent on clinical duties in the hospital, or is it more focused on administrative tasks, teaching, and research? I would say the first answer is depends. Um, if I am on service, meaning I am the ICU doctor for the week, I'm really focused on the clinical sort of stuff, and I only attend to the administrative research or other stuff only if it does not interfere with my clinical work. So I will cancel a meeting. I will not show up to something if the clinical work um, uh, is primary. When I'm off service, like I am this week, so sort of when I say off service or on service, so as a full-time ICU doctor, my responsibility is 13 weeks of service a year. So it's like 1 week a month, plus about 40 overnight shifts per year. So it doesn't seem like I work a whole lot, but I am in the building, on call, all that sort of stuff. And so, and most academic physicians, because they have such responsibility in global in research and administration and stuff like that, we take a little bit of a pay cut because the rest of the pay goes to support these other endeavors. So if I'm not on service, I really am sort of focusing on writing, getting protocols out, that sort of stuff, and administrative stuff. But usually I do them all at the same time. I tell people that critical care is like war. So there's a fair amount of sitting around waiting for something to happen. And then we run, we go do our thing, and then we debrief it, we settle down and wait for the next thing to happen. Did that answer your question? Okay, great. Go ahead. That's your hand up.
Yeah, sorry about that. Thank you for the presentation. I just had a quick question for you. You mentioned how the ICU is a very fast-paced environment where there are a few days that are the same and without interruptions. So wanted to ask, like, I'm curious to know what your approach to stress management is in those kind of environments, and what do you do to help organize yourself, help regulate yourself, and kind of carry on throughout your day?
Yeah. So I think that a fair number of us who work in the critical care are adrenaline junkies. We just don't jump off buildings. The adrenaline comes from the ICU. And so a lot of us are dysregulated when there's nothing to do on the other side. So a lot of us are antsy, walking around, trying to find something to do. And so like a lot of ICU people are much like me, talk fast, move fast, a lot of caffeine, that sort of thing. But critical care can be very intense, right? You're at risk for burnout because you are working off shifts. There's a lot of stress that comes with it. And so part of that is making sure that you sort of know yourself very well, so that you don't fall into bad habits. As a fellow, I know my second year fellow, I couldn't put my pants on. And it was because I was medicating my stress with alcohol, and I was eating fast food, right? And that is not a sustainable way to go about things. And so sort of being honest about sort of how I was taking in substances and how I was self-medicating stress during that time, I think was informative. And I think there are a lot of people who work in medicine who have some bad habits when they're dealing with stress. The other part of that is, understanding your support system and leveraging them, and leaning on them. But one thing I always tell the resident is that, the residents and the fellows, like, you were interesting before you became a physician, right? And so go back to those things that made you interesting, you know, your hobbies or the things that you did before. You may be able to do them with the same frequency as you're able to do them before, but going back to them, I think, is restorative to balance, and sort of being, I think, mindful of sort of where you are. When I was thinking about, when I was sort of a young attending, trying to get my research career off the ground, I felt myself being burnt out quite a bit, and sort of realized that, like, things take time. And so being gentle with yourself, and being patient is also, I think, helpful when you're in practice, but also it's helpful to you guys. There is no perfect route, right, to medicine. And so, and there are a lot of people who pontificate about their perfect routes through medicine. They're lying to you. And so, be gentle and be patient with yourself. And you're gonna make mistakes. And you're gonna make mistakes and you're gonna have a bad outcome. But as long as you sort of honest with yourself and you sort of are able to exercise control of the things over which you have control, that is what keeps you having a long career. And that helps you keep you regulated.
Thank you so much for sharing that.
All right, so we have a couple questions from the chat. So
Okay.
Layla has a question. What was the hardest part of the journey to becoming a physician? What was the biggest lesson that you've learned, and in turn, what that we can learn?
The hardest part of joining to a physician, you know, I think it's the delayed gratification. I think that if, like, you're pre-med and you're in college, like, and you're a science major, like, you're not doing everything else that everybody else did, right? And I think that was the hardest part. I think about it is that it was putting energy into a goal that really seemed really far away. at 18 years of age, right? And saying, I'm going to be a doctor. If I do it right, I'll be a doctor by 25, 26. That's hard, right? And so I think was the hardest part. Because I think once you're in, it's all sort of gravy, it's sort of, you just sort of stick to it and you're going to get out on the other side. And I would also say, like, being thoughtful about sort of what my choices were. I think you're making a lot of big decisions, in your early 20s. So I think the hardest part. And what's the biggest lesson that you've learned and that you guys can learn? Um, the biggest lesson? Wow. Okay. Um, I would say two things, right? Be honest with yourself, right? And that's hard. Is being honest with yourself about what are you willing to sacrifice to get through this, right? And be honest with yourself about whether you're willing to do that or not. And I think the other biggest lesson is, like, be nice to yourself, man. Just like, I think I'm still learning that, right? People who, pre-health students, medical students, residents, and fellows are very, very critical of themselves. And so, and attendings, right? We remember the bad things that we did, the test we didn't get the score we wanted on, the patient outcome that wasn't what we wanted to be. We remember all the failures. They stick to our forefront. I think stronger than other things. And so sometimes you sort of have to remember that, like, you're doing a good job, right? And the bad things that happened are eventually small to all the good you've accomplished with your career, with your pathway. And so I think those are two big lessons I think that I would have for you, right? Because you choose your own path and you choose how you get there. But be nice to yourself. Because that's you have to be able to do this for a prolonged period of time, right? You think about how much it costs you to get here, and what you're going to get paid to do that. I think one of the few ways for repaying that educational debt back is making sure you can have a longer career in medicine.
All right, lovely. Okay, and then Yasmin asks if you could do medical school all over again, would you choose the same path?
I would, right? I would go to medical school again. I would do pediatrics. I would do critical care. Like, peds critical care is like, that is me 100%. Um, and Was it stressful? It was. And I would say this: would I do it again at my age? Absolutely not. I'm tired and old. But I think with my youth, I'll definitely do it again. I'm proud of what I do. I'm proud of where I do it, and I'm proud of who I do it for. So I think, yes, 100%, I want to do it again. Nahum, go ahead.
Yeah, for sure. You mentioned also that you're able to find that PICU is kind of right for you because of just your personality type, how you like to work. But what was the trial and error process involved in that, like finding your ideal career path? Could you just kind of like walk through what that looked
Yeah,
like for you?
yeah, 100%. So I tell people this: you want to be a doctor, and that's the only thing I know how to be, right? So that's what I'm talking about. Those are my examples I'm going to use. Do you like sick patients or not? Right? And so that's my divine line. So I like taking care of sick patients. I do not like taking care of healthy patients. Right? And then I sort of found that in that every rotation that I went through in medical school and in residency, I liked the sick patients. And so, for instance, in HEMOC, right, you have an inpatient HEMOC ward. As an intern, you're taking care of the patients on inpatient ward. As a second year, you're in charge of the bone marrow transplant kids. And there, you can start vasoactives and do all sorts of crazy things you can't do on the floor. And as a third year, you're supervising them. And I love the bone marrow transplant piece. I love the sick patients, love tinkering with their stuff, loved it. In the emergency room, like, I was excited to take care of a kid who came in sick, but was like, I gotta talk to this mom about like a cough and diarrhea and ear infection, like that sort of like that reassurance that you brought your kid in, we found the problem is, but your kid's not that sick. Can you go home? We had a robust hepatology rotation. I loved acute liver failure, but I realized like I don't want to do like all the things for this one portion of sickness, right? And so that was a lesson, right? It's like you like this. It's not the patient itself. It's the patient the reason I like taking the patient because the patient was sick and the patient needed specialty level or higher level of care. And so that was what sort of cemented my career as an ICU doctor. Now, I try to convince myself that I didn't want to be an ICU doctor because the specter of doing another 3 years of training after I'm done my PEDS training, and you're tired as a resident, right? And I was like, I can do that in 3 years. Maybe I can do emergency medicine. Maybe I can do hospital medicine, right? But I couldn't shake critical care, right? And the reason why is that no matter how sick it was, who was involved in their care, they all had to come to the ICU, and that the ICU doctors sort of ran um, the the top down, left, right of these kids' care, and all these big bad people, cardiac surgeons and neurosurgeons and general surgeons, all sort of stuff, still relied on the expertise of a pediatrician to take care of their kids. And I thought that was very cool.
That, that makes sense. Thank you for sharing.
Do you want me to do this question
Oh,
in the chat?
oh yeah, I don't think we got to Eva Lynn's question, right?
Yes.
All right, so she asks, any suggestions or advice to communicate more effectively, and any tips when need to deliver bad news and things like that?
Yeah. I deliver bad news a lot. And the way that I say it is to be honest, tell the truth, right? Um, and to sort of say, and also to practice, right? So I'm gonna have this family meeting in 2 hours, right? It's preparing for that, right? It's getting all your ducks in a row. It's making sure you got the kid's name right, right? And so I've had family meetings in which the doctor was coming in to deliver, certain news and didn't know it's boy or girl, didn't know what the age was, didn't know the name, right? And so you are sort of preparing, getting the kid's name in there, in their head, in your head, and making sure you got the gender correct, making sure you got all the facts that are important, that they're there. So you're preparing and practicing, and you're sort of practicing mulling in your head, what are you going to say and what's most important to convey, right? I think in some conversations that we have, we want to be able to say everything that is on my mind and expect somebody else to hear it. And so sometimes I'm communicating one or two important facts and letting the family digest that. And then we're having a series of conversations to go over. Because I've also learned over the years that if you hit people with a lot of information, a lot of bad news, they're not hearing beyond a certain point. And so it's practiced, it is prepared, but it's also telling the truth. And the truth as you understand it as the physician, right? I deal with people who have strong faith alignments. I don't poo-poo their faith. I said, you know what? That is, I hear what you say, and I'm going to operate in your faith and walk in that. However, the ICU doctor in me has to convey this information to you. I need you to hear that from me, and then we can create a plan going forward. The other part of that is once you communicated what it is that you have needed to say, you turn it over to the family, let them process it, and let them talk it out with you and amongst themselves, right? And allow them to process. Sometimes that's sitting in silence while patients or families are trying to sort of process what it is that you are trying to say. And come in with no agenda other than we're gonna have a conversation, right? We're gonna talk. What the output is whatever the output will be. But the agenda is a conversation, and then we will figure out what the output is while we're talking together. And so I would say like, that's sort of hard. I mean, people, palliative care, that's a whole other fellowship program. but like sort of like how we sort of communicate in the ICU is practiced, simulated, all that sort of stuff to be able to communicate news to families in the ICU. And then one last thing is understanding where their parents are, where the family is, and meeting them where they are. And so if you're talking about, I don't know, something like, let's say like extreme, sort of talking about brain death, and the parents aren't sort of in a place that um, they can hear all that news, but the kid's otherwise stable, you can give them 6 or 8 hours to sort of have a conversation, to talk it over, and to circle back. That is also a way of sort of cultivating alliance with the family when you're talking about shared decision making.
All right, do we have any other questions? You guys can like feel free to unmute or put it in the chat box or anything like that. Oh, Dr. Holloway, did you get any questions like directly to you? Sometimes they do that.
No.
Okay.
No.
Okay. All right, I have a question for you.
Yeah.
I was wondering, what do you think was your most like difficult case to work with?
Oh, they're all difficult for various reasons. So I'll tell you one. And this sort of, I think this is every ICU doctor has a grow up moment in the ICU. Like there's that you're a big boy now, right? This is you. Um, so it was a kid. So he's a triplet. And he came in preemie, but like otherwise sort of at home growing, came in with abdominal pain, that sort of stuff. And in the emergency room, was seen by everybody, saw the surgeons, couldn't find anything, got a CT scan, got ultrasound, all sort of stuff. Kid was also had sepsis, and so got admitted to me. I think I was a late first year fellow, maybe early second year fellow. And got the kid to the ICU, and I did not recognize that this kid was going to arrest on me from shock. And while I was preparing to put a central line in this kid, the kid had a cardiac arrest. We did prolonged resuscitation, and otherwise the kid died, right? And so there are two lessons, right? And so one is that we always talked about our critical events, and our chief of critical care, sort of we tell the story and sort of what happened, and you know, kid ultimately had a bowel issue that we just sort of missed, despite us doing all the right things to figure it out. But what our chief of critical care said is the lesson you learned is that you'll see a kid like that now, and he'll have tattooed on his forehead, "I'm about to die." And so, how do you sort of get in front of that as an ICU doctor? But the lesson for me, the hard part came later, in that while still on service, probably a few days later, the mother came in with the other two kids to the ICU because they both had a procedure and needed to be at the ICU for overnight monitoring. And I was very uncomfortable being the doctor for that family again, afraid that the mother's going to blame me, all the sort of things that sort of come back and sort of with that environment. And my senior fellow was like, absolutely not. You get over there and you sort of confront your own sort of internal fear with that. And the mother recognized me, and she was very appreciative of all the things that I tried to do for her child. But I think being able to, I think the lesson for me was that growth, that like, children will die, but the families will still come back, and the parents will still expect you to provide excellent care for their child. And the bad things do happen despite your best effort or not your best effort, or things that you've missed. But I think that situation, I think, sticks out to me most as a critical care fellow. I think that's most difficult for me because I had to grow up a lot very quickly in those situations. there's always difficult patients that like do crazy things or like why. But I always think about the patients and the families that caused me to grow up very quickly, and sort of informed my practice moving forward.
All right, thank you. Are there any other questions? Last chance. All right. I guess we're good. That was a very informative Q&A session. So, okay, I will continue with the wrap-up presentation. So I'm going to share my screen once more.
Okay, I'll stop sharing.
Yeah, thank you.
Sorry, I'm trying to. Oh, there it is, right here. I'm sorry.
Oh, you're good. You're good.
All right.
All right, can you guys see my screen? Okay. All right. Thank you so much for that wonderful, very informative presentation, Dr. Holloway. All right, so I'm just going to go into our wrap-up presentation. All right, so we would like to encourage everyone to reflect on the session today. So we just have a couple questions on the screen. So what brought you to the session today? What are 5 major takeaways you got from the presentation? And what do you want to learn more about? So you guys can feel free to drop your answers in the chat, totally optional, but we'd love it if you could reflect on the presentation. And of course, like writing and answering the questions is totally optional, but if you could, we would encourage you to submit it to our website. We have a lot of different articles and reflections and reviews on the website, so feel free to submit your answers there. All right. And once again, if you want to learn more about pre-health shadowing or get involved in our programs, we encourage you to visit our website. There's some links on the screen. You guys can type those in, or you can just find our website just by looking up pre-health shadowing online. And we encourage you to maybe become an asynchronous volunteer or possibly a team member to really assist with all of our initiatives. And once again, we are humbly asking that if you are able to possibly donate and consider sending a few dollars to us via Venmo or PayPal. There's a QR code on the screen. You can take a little screenshot of that and look at that later. It does cost quite a bit to keep our programs running, so if you could donate, we would very much appreciate it. All right, now for the part that we have been waiting for, receiving a digital certificate for attending. So there's a couple steps on the screen that you can follow to take the quiz and get your hours. So number 1, you can visit our website and find our professionals course page. So that would be Dr. Adrian Holloway. It should be at the top somewhere probably because it's one of the more recent ones. And then number 2, you can take our 10-question quiz, multiple choice quiz based on the presentation. It's not super difficult, we promise. It's as long as you've been listening, you should be able to answer the quiz pretty easily. And you can also pass, you also are given 2 tries to pass. So you only need like, I believe it's 70% to pass and get your hours. And if you have any issues with that, please contact us. We totally get it. Technical difficulties happens all the time. Totally get it. You can totally contact us or find our email on the website and things like that. All right. And then third, once you have passed, you can click the finish course button at the bottom of the professionals page and download your certificate and then receive your hours. All right. So if you missed any part of the session and you want to go back and view it, we always like to record our sessions and put them on YouTube and also on our website. So feel free to rewatch that in case you missed anything or you just want to rewatch a part that you were very interested in and want to learn more about. You should be able to find that where you find the quiz after you look up the professional's name. So once again, Dr. Holloway. All right. And be sure to follow us on social media or subscribe to our email list for the latest updates on upcoming sessions. We have social media on Instagram and things like that. Be sure to follow us. And we want to thank you for joining us today. Please stick around if you have any lingering questions. Myself and other team members are free to answer that for you. I'd like to say that this shadowing session is officially over and we invite all of you to log off unless you have any questions. All right. Have a good day, everyone.
Thank you for having me. It was lovely. Thank
Yeah,
you.
of course. Thank you,
Thank
Dr.
you.
Holloway. All right. Bye,
Take care.
everyone.
Bye.
All right. Did you have a question? Okay. Guess that's it.